all the other case discussions, we're going to begin our conversation remembering that these are the questions we want to focus on. First, the behavior of the lesion, and then, of course, the clinical presentation. And this is how you make your differential diagnostic list. And based on the test that you run, then you can narrow it down to the ultimate diagnosis. Our first patient is Sarah. She's 59 years old. She comes in complaining about pain and swelling in her gums. She has a rather complicated medical history, has had a liver transplant a year ago, has also high blood pressure, type 2 diabetes, and anemia. Look at her medications. I think you are getting to a point where in your training, where by looking at the list, you should be able to pretty much understand what each one of these drugs do and how do they relate to her medical diagnoses, right? Mycophenolate, cyclosporin, sirolimus, cotrimoxazole, fluconazole, valacyclovir, famotidine, amlodipine, metformin, and also the estrogen supplement. I'll just give you, 1 minute, digest all of these and try to connect them with her medical conditions. Let me show you what is going on in her mouth. For the past 5 months, she's been getting these swelling in her gums, and she said that the swelling is getting worse. They bleed spontaneously. She says that she can actually put her finger on the gums, and when she squeezes, she feels like there is pus coming out. She doesn't have pain, interestingly enough. So that's her gingival presentation. You can see most of the swelling is in the buccal, but you also have some degree of involvement on the lingual, especially this bulbous tissue here, the tissue between the premolar and the molar, and to a point where most of the teeth are almost like buried inside the gingival hypertrophied pieces. Okay, so without any interruption, let's just do our first poll. Okay, excellent. This one you have to think about a little bit. So it looks like all of you were kind of conflicted in terms of what the actual correct answer might be. Why is hormone-induced hyperplasia not a good option in case of Sarah? Medication-induced, if you go back to the list of her medications, we definitely have cyclosporin that we know can cause gingival hyperplasia. Then you have amlodipine or Norvasc, which is a calcium channel blocker. So both of these are notorious for causing gingival hyperplasia in people who use them long term. You also understand the little nuance with these, that this actually, the hyperplasia usually happens in people who don't have really excellent home care. So you have a bit of a contribution by dental plaque that is involved in causing the inflammatory response in the gingival tissue that then goes haywire and becomes really fibrotic, and you end up having major hypertrophy. So the medications, definitely, she does take medications that can be responsible for her condition. Can you have periodontal disease causing hyperplasia? Chronic gingivitis can lead to hyperplasia, so it's not unusual for people to have that. Hematopoietic malignancy, I think you have seen all of us in the oral diseases tell you that you can sometimes have hematopoietic malignancies that can infiltrate the gingival tissue. And anytime that you see someone with that degree of involvement, you have to rule out hematopoietic issues. Hormone-induced is not really likely. You know that there are some potential changes that can happen during puberty, during pregnancy, and then sometimes in men who take androgens for replacement medications that give them reduction in testosterone. They can be taking like agents that are androgenic, and they can cause hyperplasia. But female hormones have not been connected. The estrogen replacement therapy in men has not been connected to gingival hyperplasia. So of all of these, we don't have, that's the one that I would go for. Yes, Mustafa, you have a question?
Yes, Dr. Yunai. So I put periodontal disease, and I wasn't actually sure why isn't periodontal disease could be the case. Like, I don't know, there's like a periodontal disease that would look like Sarah's case?
Yeah, the question I was going for was which is not a likely. So periodontal disease can, so that's why it is a good option.
No, I was just confused. I was just a little bit confused. Like, is there a periodontal disease that would look like Sarah's case? Like, can we?
You can have gingival hypertrophy from periodontal disease, yes. Now, whether it can involve all of the teeth or can be in some section of the mouth, that's a different story. But in terms of mechanism, yes, you can have chronic periodontal disease can cause hypertrophy.
Okay, thank you.
So the next piece of information we have about Sarah are her laboratory values. And because of that potential for hematopoietic malignancy, the first thing you want to do is you want to look at least her white count and differential. So this is a fishbone presentation of labs. If you have never seen it before, this is just a lot of times shorthand is done in medicine, where you have your white count, hemoglobin, hematocrit, platelets, and then you have your RBC number and indices on the side like this. So when you look at her numbers, her white count is okay, which is actually good, right? Because then if she had any form of hematopoietic malignancy with white cells, you would expect the white count to be elevated. And not only that, I didn't give you the differential count. Usually when you have elevated white count, then you look at differential count to see if what is a population that has expanded? Is it the neutrophils? Is it the lymphocytes? But her white count is okay. But her hemoglobin is low. Normally for women, you're looking at 12 or 13, and her, she's 10.5. Hematocrit, she should be around 34 to 35%. She's about 32%. Her platelets are okay, but when you look at her red cells and her red cell indices are all depressed. They're lower than normal. So there is no question that she has anemia. No evidence of malignancy. The other data that we have from her is that her pockets are 5 to 6 millimeters, and there are some bone loss that you see on the radiographs. You do culture and sensitivity from one of these gingival sites that has purulence, and it grows Strep pyogenes and Staph aureus. And they do a sensitivity test, and it shows that it's sensitive to penicillin, erythromycin, and tetracycline. That's a typical culture sensitivity response you get. Okay. Okay, it looks like we are at the. Okay, more people responded. Okay, let's see what everybody's thinking. So most of you went with A and C, even though we still have some people who answered B. And that was the correct answer. So I want to remind you in terms of the choices of antibiotic that we have. These are antibiotics that inhibit protein synthesis, and you have tetracyclines, and then you have macrolides and clindamycin. The macrolides are erythromycin, and then clarithromycin and azithromycin are the other members of this group. Erythromycin has very poor tissue concentration. So erythromycin is really not a very good medication to use, especially in locations where you need significant amount of antibiotic to be delivered to the tissue. So it doesn't really have a, doesn't get distributed as well as the other members of this class. That's the one thing you have to remember about erythromycin. But of course, the other ones like azithromycin, clarithromycin, and even clindamycin, they're all excellent choices in terms of their spectrum of activity. Erythromycin aside, so this is the beginning of me giving you some ideas about drug interaction. So through these cases, I'm trying to get you familiarized with most common drug interactions in dentistry. Erythromycin is one of those antibiotics that you are going to write for. I mean, is a choice, as you saw in the sensitivity, is something that dentists write for all the time. But one thing you have to remember about erythromycin and macrolides in general is that they do interfere with drug clearance. And of all the medications, the ones that are sensitive to drug interaction, you have to know right off the bat. You have to know cyclosporine is one of those medications that is an immunosuppressive agent, and a lot of people with autoimmune conditions or post-transplant are taking cyclosporine. And whatever you write, you don't want to interfere with that because the effectiveness of this medication is going to change. The inhibitors, macrolides and erythromycin and macrolides in general, they are cytochrome P450 inhibitors. So the drug builds up in the blood. It doesn't get metabolized as fast. So instead of having mild immunosuppression, that's what you need for prevention of organ rejection, she's going to experience profound immunosuppression, and also is going to put it in the range of nephrotoxicity. So drug interaction with macrolides, and of course the cyclosporine being super sensitive to that kind of interaction. This is what I want you to remember from this case. Now we get to the actual management of the lesion. What do you think, what would be the best management for her? Which is actually the one that you don't want to do right away. So most people went with gingivectomy not being really the correct approach. And it sounds like a perio question, but really is not a perio question. I want you to, pay attention to the fact that you have an active infection right now going on. So you have to allow the tissues to change at some point, maybe their architecture, before you can decide exactly what it is that you need to treat, because gingivectomy is not reversible, right? So treat your infection first, allow the tissues to maybe resume normal, their normal function, and then see what you're left with. And it's possible that she will have some pseudo pockets that you're going to have to eliminate through gingivectomy. But of course, the idea is for you to treat the infection. In terms of the treatment, tetracycline was one of the antibiotics that she had her sensitivity test showed reaction to, so that's a great example. Tetracycline would be a great antibiotic to use. Chlorhexidine is a topical medication. We haven't talked about topical treatments, if this is going to be our next discussion, but in the range of topical medications, chlorhexidine has a pretty good role to play in this case. And of course, you want to eliminate as much as possible plaque and contribution of more bacteria in the tissue. So doing an SRP and home care would be great. I would not necessarily be very aggressive with my SRP. I probably would be just trying to debride, but you want to eliminate the bacteria mechanically as much as you can as you deliver medication to it topically and then systemically. So that would be the approach for the case that you're looking at. So gingivectomy was the right answer. So let's go on and look at another case. This is another type of infection now. This is Lois. She's 76 years old. She started having pain in number 5 3 weeks ago. You're treating her for a different reason. This is a patient I saw because I was treating her lichen planus, but she came in and she had this lesion, and she has been taking ibuprofen for pain, but she says that it doesn't work anymore. Her medical conditions consist of, other than lichen planus, osteoarthritis and hypertension. She's taking an ACE inhibitor, meloxicam, fluocinolone gel that she's using for her lichen planus. And you see this lesion next to tooth number 5. In your diagnosis, it is a sinus tract. This tooth has an occlusal amalgam and a cervical composite. And when you take a periapical radiograph, you see periapical pathology associated with the root of number 5. You drain it, and you obtain some purulent material that you send to the lab for bacterial culture and sensitivity. And let me just mention this. I said that in the lecture. A culture sensitivity test takes about 7 to 10 days to come back, the result. So you always have to make a clinical judgment. Start a patient on an antibiotic that you think would be effective until the result of the culture comes back, and then you can see if you gave the patient the right antibiotic or you need to switch it. But you have to write something today based on your knowledge of the infection she has. That's the question I'm asking now. Majority of people went with penicillin V, but we had also the other choices also picked by a few students. So let's take a look at that. The answer is penicillin V, and there are good arguments about why penicillins in general and why not, cephalosporin or tetracycline.
Dr. Unai, is penicillin V the same thing as penicillin VK?
Yeah.
Okay, thank you.
So just going back for 1 second here, we always try to go with oral prescriptions anyway, right? So penicillin G is injectable, is IM injection, so you're not going to go with an injectable. So if you are going to go with penicillin, you're going to go with penicillin V. Then you have to think about the difference between penicillin V in terms of a spectrum and the kind of bacteria you're trying to cover, as opposed to cephalosporin or tetracycline. You remember that these are beta-lactam antibiotics. You have penicillins and cephalosporins, and penicillins break into those that are narrow spectrum and those that are extended in their spectrum. Their narrow spectrum, they do have beta-lactam sensitivity, and those that are resistant to beta-lactamase. Penicillin G and V, they're both beta-lactam sensitive narrow spectrum antibiotics. But in terms of their spectrum of coverage, you think about this is a non-intact tooth. It has amalgam and a composite. So you expect to have a mix of gram-positive and gram-negative and a few anaerobes, but you probably are going to mostly be gram-positive facultative type of bacteria that are not predominantly anaerobic. So you really want to go with an antibiotic that has the right coverage for that kind of organism. The extended spectrum one are not going to be a bad choice. They just cover a few more. But if you really are trying to stay very focused on the infection, you don't need to go to an extended spectrum because you really want to only treat the odontogenic infection at this point. Cephalosporins are in general are broader in the spectrum, and you really don't want to give a cephalosporin unless you suspecting that you have a mix of organisms that are, you need to have that extended coverage. Again, you remember, you want to give the as targeted as you can be against that specific microorganism that you're suspecting, and yet with the strength, enough of a strength that you know is going to take care of it. And this is the spectrum. This is a table that I'm gonna post the case so you have this table. This is not from my lecture, but I think it's a good recap. I like to show this table after you have studied all the antibiotics and after we have done some of the case discussions in terms of what do they cover, right? So your beta-lactams, which are the ones that are sensitive, being penicillin V being one of them with narrow spectrum, it does cover your strep, all the strep organisms that you suspect in an odontogenic infection. It does cover the staph in case you have a few organisms, and you have some gram-negatives and anaerobes also covered in that. Beta-lactam, the lactamase resistant ones that are still narrow, they will give you a little bit more of your anaerobes and a few more of your gram-negatives. The extended spectrum ones, and of course you remember that they cover the staph and the strep, plus the HELPS group of organisms, and some of the gastrointestinal bugs. And the cephalosporin being broad, they usually are used when you suspect Pseudomonas. I mean, Pseudomonas are a lot of times gastrointestinal bugs. You can get oral infections that get contaminated with Pseudomonas, but you're not going to see them as a just normal part of an odontogenic infection. Reminding you also about the other classes of antibiotics, like inhibitors of protein synthesis. Tetracycline is the one that is broad spectrum, okay, and covers a lot of anaerobes. Clindamycin and macrolides are both narrow, and they not only cover gram-positive, strep and staph, but also they do have some effectiveness against anaerobes. And then you have your nucleic acid inhibitors that are metronidazole and quinolone. And of those, quinolones are the broad spectrum. So you add nosocomial infections to this one. So everything here that you see that are the three purple choices that we have are the ones that you probably were in the question. right? The choices that I gave you in the answer. And of all of these, you have two of them that are broad spectrum. And treating one tooth with odontogenic infection with a broad spectrum antibiotic is not a good idea. It's too much. You really want to give something that is very targeted and to the point. And a lactamase sensitive agent like penicillin V would be adequate. Now, let's consider this now. Okay, so majority will be tetracycline, and then the next one would be amoxicillin clavulanic acid combination. And of course, that is the right answer. Start considering this again one more time, that you went with a narrow spectrum that you thought that would be targeted to the organism, and knowing that it's beta-lactam sensitive, you may want to go with a choice that gives you beta-lactam resistance. And that's the next step. So you kind of take it one step higher and just give the combination, because that's going to be, again, strong enough, and yet you don't have that beta-lactam sensitivity. Again, the rest of these, cephalosporins, tetracyclines, and ciprofloxacin, they're all broad-spectrum antibiotics. So do you see the theme, what I'm going with here? You don't give the strongest possible antibiotic right off the bat. The key to antimicrobial treatment is, again, to stay targeted, and it's something that is just strong enough, because you need to have the ability to step it up, right? Because if you end up having a resistant organism and when you give a broad spectrum, then you don't have too many choices after that you could use. So you really want to leave yourself room for that. So you go kind of, you kind of guess the microbial origin, You give what you think is going to work. If you think that you needed something a little bit stronger, then you go with something a little bit stronger. But you don't go from something that is narrow spectrum all the way to something that is broad spectrum. That's too much. And again, reminding you that clavulanic acid adds that beta-lactam resistance to the mix, and that's the reason what you want to go with. And reminding you again that cephalosporins, tetracycline, and quinolone, they're all broad spectrum antibiotics. Let's talk about William. William is 16 years old. Started getting these lesions after they put the orthodontic brackets on. He's very healthy, has no medical history, has no medications. He says the area is extremely painful. He cannot brush. Sorry about that. I cannot shut off my phone, unfortunately. He does have bad breath. He thinks that, this is causing significant bad breath. And of course, he feels that there is a lymph node under the jaw that is hurting him. So take a look at the distribution. So you have a little bit of change in the tissue here, and then you have, of course, this area here. Are you kidding me? So let's do the poll. So almost everybody went with all of the above, which actually the right choice. Now let's talk about these for a second. Peroxide. What is the benefit of using peroxide? What do you think? It does have antiseptic properties, right? So you know that peroxide is a disinfectant. You could use it for a lot of, wound care and the superficial cleansing of an open. Sorry about that. This phone goes back to when Dr. Mito used to be in this office, which is this is an old phone. I cannot turn off the ringer, and his Zoom meetings with this phone has been very interesting. So peroxide, it also has, because it has the bubbling effect, it actually does mechanical debridement for the wound. So anytime that you want to use peroxide one of the reasons that when you flush, let's say if you have a paper cut or you have a cut on your hand, you want to use peroxide is because that bubbling effect that allows you to actually get some superficial cleansing of the wound. Of course, you need to improve home care, but why metronidazole in terms of antibiotic? You remember that this is most likely, but I'm going to go back and show you the picture. You not only have this ulcer here, but I want you to pay attention to what is on the surface of the wound here. There is a pseudomembrane there, something that you would be able to kind of try to wipe away. And when we call something a pseudomembrane, basically what we're saying is that there is something loosely adhering to the surface of the wound. And this is what the patient has. And in terms of a clinical diagnosis, the best thing that we can go with is a possibility that this being necrotizing ulcerative gingivitis. The organisms that are involved in this, you remember that these Fusobacteria and Borrelia vincenti, these are gram-negative, these are anaerobes, basically, that are strong periodontal pathogens. And for the treatment of NUG, there is always a recommendation to use a peroxide. And if you are going to do systemic treatment, you want to use something that is effective against spirochetes, and that's your metronidazole antibiotic.
So, Dr. Nina, would you say that's a pretty severe case of NUG that we just saw?
No, it can get a lot worse than this. In this case, actually, the NUG is mild because if you ever see the actual presentation of NUG, the pseudomembrane is so thick that it's so painful. Even if you try to remove it and wipe it away, the patient is going to be jumping out of the chair. It's extremely painful. So he had actually a very mild case of NUG, but he responded. Yeah.
Like as far as a question on the test kind of goes, the slide said in a severe case you'd want to use metronidazole. How do we differentiate at what point it's severe enough to use metronidazole? Stepping back to when you said you want to start out with just enough treatment and you then have room to give more and more.
Right. So with this case, you could only do debridement and see how much resolution you get, right? But if you were going to write an antibiotic, then you definitely want to go with something that has the right spectrum of activity. I think that one of the things that you kind of go with is the amount of pain that the patient had. He was severely affected by this. He couldn't eat, he couldn't function. So that's the reason why we added the systemic medication to the mix. But you could begin with the peroxide rinses. But when I say peroxide rinses, it's talking about every 2 hours, right? Very aggressive peroxide. And then good home care. And in this case, even if you wanted to add chlorhexidine, you can. But I think peroxide will do the job. You don't need to go to chlorhexidine. Okay. Yep.
Is the bubbling debridement from hydrogen peroxide any different from what you would get just switching any mouthwash?
Yeah, it is actually, and it delivers oxygen to the tissue too. So if you have an anaerobe in there, so the peroxide has actually an added benefit. So it is a good disinfectant for the oral tissue. It's much more effective than just swishing and rinsing. Our last case is Ruth, and this is a 78-year-old female who comes in and says, I have dry and burning mouth. She had a stroke last year. She has left-sided weakness as a result of her stroke. She has atrial fibrillation, hypertension, and osteoarthritis, and also gets recurrent urinary tract infections. She just got over one urinary tract infection, and they told her that it was related to E. coli, and was sensitive to sulfonamide and fluoroquinolone, and they just gave her a 1-week course of ciprofloxacin, which is a fluoroquinolone. These are her medications: digoxin, enalapril, hydrochlorothiazide, Coumadin, and oxybute. Again, relate each medication to the medical condition for a second. Um, she there is an effect that you feel that she suffered from her stroke because her daughter keeps answering the questions for her. She's not very responsive. She does have burning sensation in the mouth, and she does have these lesions inside of the mouth. And then there is a periodontal abscess and mobility tooth number 30. So there are a couple of things that are going on in the case of Ruth. So most everybody went with Coumadin, then the next one is digoxin, and then the other two medications. So let's talk about this kind of interaction. So there is different kind of interaction. I'm going to post that material for next class. There are different kinds of interaction that can happen. This one is through the fact that oral anticoagulants, they're protein bound. And when you give antibiotics like sulfonamides, they actually displace them from their binding site. So what you do effectively is that you increase the amount of medication that is free, and but the availability or the bioavailability of the agent is going to increase. So that kinds of increases the risk of bleeding in the patient. So that's the kind of interaction that you would expect with sulfonamides and Coumadin. Let's answer one more question about this. This one you really have to think about.
Dr. Yanai, are we picking? You said 3 of these are incorrect. Do you want us to pick the incorrect one?
No, one of them is incorrect.
Okay.
Something to wake you up. The key is how do you the pairing, right? Which one is the wrong pair?
That makes sense. Thanks.
Okay, I think this is as much as we're gonna get. So let me stop polling. Obviously, you all agreed on the answer here, right? So let's talk about why these are. I'm gonna go back and show you the lesion first of all, so you can appreciate. So you have an odontogenic or maybe slash periodontal, we don't know, abscess here. There is no question about that, right? So there is the infection here you have to deal with. Then you have this, which is all these areas of white changes that are on the floor of the mouth and ventral aspect of the tongue. They look like they're diffuse, they don't have a specific shape to them, and your best diagnosis clinically would be that they are candidiasis. And remember that she has dry mouth. It's possible that her dry mouth is playing a major role in her getting yeast infection. Now, you want to give her an antifungal that works, right? So you have choices. If you remember the antifungal lecture, we have clotrimazole, which is a topical agent. We can use nystatin, which is again another topical agent. Then you have systemic medications like fluconazole and itraconazole. Now, in terms of the choice of an antifungal, any of these would do, but there is a reason why you shouldn't or cannot use them. Definitely, itraconazole interferes with metabolism of coumadin. I'm going to show you that in the next couple of slides, which is another drug interaction. Fluconazole and toxicity of digoxin. Azoles in general, they do have a significant drug interaction, and two of the most sensitive medications here are digoxin and warfarin, very sensitive to drug interactions, and you don't want to interfere with them. Nystatin may not be such a good choice for her because it has a lot of sugar content inside of the preparation, and in somebody who has dry mouth, you may not want to give them so much sugar, something that bathes the teeth on a regular basis. Clotrimazole is a good choice you could give to the patient. and I would not withhold it because there is no absorption. You have to remember that clotrimazole, even though it has azole at the end, is not a systemic medication. It's a topical medication. It doesn't get absorbed anyway. So that was the wrong pairing that I was going with. So let me just tell you a little bit about these drug interactions. Systemic antifungals that have azole in their name, like ketoconazole and itraconazole and anything with that in that family, they do interact with digoxin and coumadin and lead to the drug toxicity. They prevent their metabolism. So digoxin, and this is one thing that we always talk about in medication, the spectrum of dosage. There are medications that have a very narrow spectrum, or the therapeutic, the margins of error are not very high. Digoxin and coumadin are both this kind of medication. A slight increase in the digoxin level in plasma, it leads to severe bradycardia in the matter of 10th of a milligram. You don't want to interfere with that. Same thing with coumadin. You know that coumadin is very carefully titrated in patients, and they usually do INR on a weekly basis to make sure the patient is taking the right amount. So a little bit of extra coumadin in blood, the patient's INR is going to go really, really high. So these are the two that you have to remember in terms of major drug interactions. In terms of the effectiveness, of course, I remind you that mycostatin is a good topical agent, but it does have a high sugar content. So if somebody with dry mouth, especially if you feel that they're going to have to keep taking it for a while, maybe giving something with high sugar content is not such a great idea. I'm going to do one last poll related to this case. Most everyone chose amoxicillin. So let's review these drug interactions. Metronidazole does interfere with coumadin, but in that case the effect is on hepatic clearance. So it builds up and it leads to excessive bleeding. Clindamycin also interferes with hepatic clearance of digoxin. So it leads to toxicity and causes bradycardia. And then tetracycline can reduce digoxin metabolism because it affects the gut, increases the gut toxicity, and it can lead to bradycardia. So these are some of the most important drug interactions that we can think about. So the mechanism of interference with these agents. So today I talked about cyclosporin, digoxin, and coumadin. The side effect profile is extensive, and of course the drug interaction is really tremendous. because we write for antimicrobial prescriptions, and I know that in dentistry we don't do it all the time, but you have to, at some point, you have to treat some kind of an infection. Every time that you're writing a prescription for an antimicrobial, whether it is an antifungal or an antibiotic, you have to pay attention to the drug interaction, especially when it comes to these three agents. I didn't post the drug interaction lecture before because it makes sense after you see these cases. It makes a lot more sense when you read it, because otherwise it's just going to be a lot of words that have no meaning. So now that we have seen at least these three different kind of interactions, I'm going to post that, and it's also part of what for the next discussion also for over-the-counter preparations. Are there any questions?
Dr. Yunai?
Yes.
Sorry, real quick. One of the cases, the answer was warfarin, and I think you were talking about sulfonamides at the time. I wasn't sure I didn't catch the explanation.
So it was this other case? No.
No, I think it was 7. You passed it.
Yes, sulfonamides. So it was the effect that sulfonamides have on coumadin, and the explanation is here, that they do interfere with the binding site, protein binding site for coumadin. Sulfonamide interferes with that, competes with that on the binding site.
I see. Thank you.
Sure. Okay, so this is not going to be your favorite class to study for. I'm sorry about that. There is nothing exciting or fascinating about medications. It is what it is. The drug interactions is one of those things that most of the time when you want to write for a prescription, and believe it or not, when you write prescriptions, a lot of times